Today's topic is influenza. Be prepared. First speaker is Dr. Jude Jayamaha, consultant virologist, Medical Research Institute, Colombo. He will be speaking on fascinating facts of flu. Over to you, sir. Please note, this session will be webcasted and webinar.
Thank you for the kind introduction. Actually, this is jointly hosted by Medical Research Institute and the Communicable Disease Subcommittee of the Sri Lanka Medical Association. So thank you very much, President and Honorable Secretaries, and all the SLMA staff. Just a very brief introduction, because influenza, we have noted a clear-cut seasonality is there over the past few years because of intense surveillance carried out, and we had several outbreaks. Very recently being Karapiti outbreak, of course, which was actually spread throughout the country. So when there's an outbreak, of course, we are very keen and we actually organize certain things. But beforehand, since we have a clear-cut December, January, February, and May, June, July, we have two seasonalities. So we thought of before the season to have an awareness symposium like this. So this is my outline, a very brief of virology, because I'm a virologist, and laboratory diagnosis and Sri Lankan seasonality, and few questions. I have actually made a small amendment to the topic. So first of all, clinical impact is actually so in our tropics and of course in our subtropics, influenza, because of other competing infectious diseases and of course non-infectious diseases, influenza draws little attention. But if there's an outbreak, of course, we do have a lot of concern and a lot of media coverage is given. So beforehand, if we can have a discussion between the major say frontline defense of all these three clinicians who are very experienced and competent of dealing influenza, it would be really good. So influenza virus, of course, there are 4 viruses now. Previously, it was there are 3 viruses. That's the point. So influenza, just the virology or second MB or the third MB, it's a segmented genome sense. It has, especially influenza A, has many species, especially alien species. So therefore, it's a pandemic potential, and it can spread, of course, which has happened in 2009. So we have the influenza B as well. So it's mainly it's human, unlike alien species. So it can cause epidemic. Of course, in the latter half of the presentation, I will be going into some of the aspects of influenza, frequently asked questions. And then, of course, we have, of course, it cannot cause pandemic because it has only 2 species of animal species that it can actually infect. So we have C, and of course, the new kid on the block is the influenza D since 2014. So uncomplicated influenza, just to have my other speakers will actually deal elaborating of complications and all that. So incubation period is very short, and followed by that there will be fever, and when the fever subsided, usually virus cannot be isolated. And then of course sore throat, myalgia, cough, coryza, which can last, of course, and the generalized malaise can last beyond. Usually it's an acute illness, of course, but whatever the symptoms and perhaps some certain signs may be there beyond the illness. So mainly the respiratory tract is affected, but of course one can have headache and other constitutional signs as well. So very briefly about transmission, because we are not dealing directly with infection control procedures as such, but it's mainly by droplet and direct contact. But when there is an aerosol generation procedure, especially sneezing, where we can actually have the small droplets where it produces clouds, we can transmit it to beyond 1 meter. But usually it's beyond less than 1 meter because of large droplets, which is more than 5 degrees, 5 microns. So there are certain groups that have as high risk. So mainly is pregnancy. That's why there's a special speaker from the College of Gynecology and an eminent speaker from the Castle Street who dealing with pregnancy, because every time when there's a death and when there are complications, of course, this special cohort come into picture. But of course, we should not forget about less than 2 years children, especially this Kanapati outbreak. There were a lot of infants who were infected with influenza, and of course, RSV and adenoviruses as well. So when there are certain risk groups, the complication can occur, and when the complications do occur, the what you call the fatality rate can go up. Little bit of oseltamivir, because oseltamivir is very interesting, because now Cochrane studies have come up saying that whether it's really effective or not. But I think this is not the forum. But we would like just to give the scientific facts about oseltamivir. Can oseltamivir regarding biological point of view, can it reduce? Yes, it can reduce. It can reduce, especially those who are having infection, especially with a placebo group. It can reduce the symptoms, the disease, as well as the secretion. So, what about the other paper intended to treat infection population? With the lower respiratory complications can be. There's a reduction of 4.5 to 8.7 in placebo. This was published in the famous journal Lancet. And what about the admissions? Few admissions to the hospital. Of course, these are all carried in European countries. No Asian studies have conclusively say whether there's a reduction. So moving on to the laboratory diagnosis, because we want to give more emphasis to clinicians, because this is well addressed in the clinical forum. Very briefly about laboratory. First of all, do we need to diagnose influenza laboratory confirmation? That's a very good question, because especially in an outbreak situation, especially which happened in 2018. So during an outbreak situation, yes, in the initial phase of the outbreak, we need to know. But pure and simple influenza, if it is in the mid outbreak, or we can call it a mid season or the late season, the clinicians, sometimes, of course, even normal doctors can high suspicion of index, they can have a clinical diagnosis. So it's mainly clinical diagnosis, not essential. Having said that, nevertheless, laboratory confirmation is needed in the early phase of the season. Now we are actually entering the season, either November, December, January, 1 month earlier, 1 month later. So we need to know what is the pattern, and whether more influenza within a short, say 2 weeks, 3 weeks period, whether it is frequently reported. And of course, mainly from our point of view, as well as the epidemiological, what is the type and what is the subtype. And of course, whether clinical doubtful cases, like whether when there are sepsis, or when there are complicated cases, sometimes, of course, especially I think pediatricians, diarrhea is one of the features that it can present diarrheal infection, diarrheal episode. So atypical presentations are also there sometimes. And of course, postmortem. We always encourage those who are suspected, especially pregnant mothers, to have postmortem confirmation, postmortem diagnosis, laboratory confirmation of the postmortem sample. And of course, this is from our point of view. Further characterization, laboratory diagnosis is actually further characterization of the virus for surveillance purposes and antiviral resistance or sensitivity. So, before moving on to laboratory diagnosis, a quality sample is quality result. This is really important. We have emphasized in many instances, because we cannot actually convert whatever, say, idling sample not transported in, and we will elaborate it further. We need a good quality sample. So what are the samples that we can take? Especially, I thought of maybe doctors are here, so sometimes they can assist the nursing staff and others to have a good quality sample. So starting from nasopharyngeal wash, of course, it's not practical, especially it's encouraging pediatric practice, but it's a very cumbersome thing. So we have resorted to nasopharyngeal swab. Nasopharyngeal swab, oropharyngeal swab. Please do not use nasal and throat swab, because these are terms and sometimes they can be misguided as well. So having said that, so we have now respiratory sample. You can have nasopharyngeal swab, oropharyngeal swab, and then of course we go beyond tracheal aspirate and lung biopsy. So when there is an actually, because even though we the main mode of sample sampling technique is uh, nasal swab and what do you call nasopharyngeal swab and oropharyngeal flop swab versus tracheal aspirate. It's not practical to have always the lower respiratory tract infection because it's a tracheal aspirate, even the nasopharyngeal aspirate. Of course, then there need to be more staff and more equipments are there. But in a lower respiratory tract patient and of course severely ill patient, severe influenza, we always encourage to have, if the patient is intubated or if the patient is critically ill, to have a lower respiratory tract sample or a nasopharyngeal aspirate. This is important because sometimes we cannot exclude the diagnosis. Time to time we do get blood for NS, say H1N1 antigen, perhaps mixing or confusion with NS1 antigen. H1N1 antigen, we have 3 samples this outbreak as well. So blood we cannot have an acute diagnosis. There are certain things in epidemiological purposes. So blood is not a good sample for testing. And how to collect it is a procedure. So healthcare worker should know how to collect it, and everything should be ready, and ideally there should be explanation. And PPE should, that is personal protection equipment. N95 is only warranted for when there's an nasopharyngeal aspirate sucking the secretions. So these are the swab that we use. And here how to take a nasopharyngeal swab and how to take a oropharyngeal swab. Ideally, you have to use a spatula, but sometimes it's not practical. So you have to say ah. They ask the patient to say ah. Then of course the ulna will go up and tongue will go down up. So this is a nasopharyngeal aspirate, especially in the children less than 2 years. We encourage this, but because sometimes, especially very young children, it's very difficult to put the nasopharyngeal swab because this is an adult one. So this is a commercially available nasopharyngeal swab and viral transport medium, which have a shelf life of 12 months, and preferably we recommend to store at 8 degrees. It is really important that we should not freeze the sample because endpoint is not. I will deal it a couple of minutes later. It's for you all. Yes, you all. It's important to know whether the patient is having influenza or PCR is positive or not. But at the national level, we need to know. We need to grow them. So please do not freeze the sample because it will kill the virus. So request form is so important. Please, there are medical officers here, there are registrars and senior registrars. Please help us to improve our services, our surveillances, our feedback, and of course to send the samples. The higher, the duration is so important. So please fill the form appropriately. This is a specific form. Of course, we do accept the normal MRI form as well. So really important the duration and whether the osalutamide has been taken, because antiviral resistance, we need to send those who are on the osalutamide. So, and the thing is, I mean, myself and my staff, we don't have the insight looking into the patient's illness as such. So it's really important to form. This is pregnancy, this is duration, and this is whether osalutamide has been started. We have come across sometimes higher doses, starting straight away with 150 milligrams. So then, of course, we can give a feedback as well. So what are the common forms? Leaking samples. As you all know, we do not know whether we are sending for influenza true enough, but we do not know whether they have MERS coronavirus. So it's really important just to secure, because it's a screw cap one. Please make sure that it is not leaking. And then request forms were not transporting and melting. These are the common forms. In shortened forms in the the request form is a very cumbersome for us. Please either place a seal or you can send it to the laboratory. So what are the tests that are available? Real-time PCR is the one, and this is turnaround time. Now, this outbreak as well as 2013, 15, 17, we do get a lot of calls. How long does it take? And we have sent it yesterday. Can we take it today? It has a turnaround time because it is done in 6 steps and in four rooms. Now we are slowly moving to automation. We have auto machines, so in time to come, it will be less. So laboratory diagnosis, very short, is very expensive, and sometimes it is only indicated in an outbreak situation in certain risk groups. And correct sample, correct storage is so important. So we do as I mentioned previously, real-time PCR is not the endpoint for detection. So it's really important for we need to continue with culture, and where there are particular downstream applications at national level, we need to know what is our resistance pattern, certain things. So when the especially in an outbreak, when 5,000 now this outbreak we received nearly 7,000 outbreak. That is twice 2-year capacity. So it's very difficult to cope up, even though we don't like we do 80%. The time is valuable time is spent on selection, storing that kind of information for activities. So Sri Lanka, we have two trends. One thing, of course, in December and other. These two are actually skewed by 2013 outbreak and 2015 outbreak. So we have uh, two two peaks, mainly toward the end of this year, November, December, and we have another peak in May. This is the same pattern 2015 2018. So we have a peak here. So I have the latest figures up to 16th of November. We have 33%. So here, of course, 28%. So November, I don't know whether you all can see here, 30%, 33%. It has gone up, but towards the mid of the month. So I mean that is the pattern. So we do not know actually. Madam Omal asked me whether it can go up. So influence is very difficult to predict as such. We do have patterns, but we can have like December, January, May. So it's a kind of a prediction of future trends. So one the other thing important factor is influenza B. Now influenza A, because of pandemic 2009, influenza A is so closely glued into our cerebral cortex. Influenza A is the main culprit. Influenza A, H1N1 is the main culprit. Even if it is H1N1, it is deadly. Especially in a death, they want to know whether it's H1, H3. That's all. Something like that. It's not influenza B also. So actually, this should be recently asked question, not frequently asked question. So waiting for the result to start, we have come across this outbreak also. So we have asked, please do not wait, because 48 hours is the maximum efficacy period. The drug itself they have treated, because the patient will come in the in the third, fourth day. So if you are suspecting, if you send a sample, that means you are suspecting and you are bound, or you are actually hoping to start. So it's very important. And of course, as I mentioned, sometimes it will take 72 hours because of inconclusive results. So what is the subtype? We need to know. I mean, we have a call log, our registrars know. Sometimes we use to, for future learning purposes, we have a call log. So they say we want to know whether it's H1N1. So we ask why. They say because even if it is H1N1, we are scared. I mean, it's not the real meaning, but they say no. Want to take precautions, especially in a death or a critically ill patient, after informing them that it's influenza A. So sometimes we cannot subtype them because viral load is low. And when we actually, when newspaper reports, or sometimes when there's a report saying H3N2, because then of course we subtype and we inform, and then they ask H3N2 whether it's influenza A. Yeah, it's a subtype of influenza A. And this is really important because this is actually a timely manner also. Influenza B, whether it's warrants treatment. There's no difference between influenza A and influenza B. If influenza B is in the guidelines says it's the same. So whatever the influenza A applicable guidelines is applicable to influenza B as well. So can influenza cause severe disease or death in that matter? Yes, it can. It has actually. So local outbreaks, especially Kilinochi, from the epidemiology unit, Kilinochi, they can have 2013, they had few deaths. And influenza B, local B positive, this year also there are 3 deaths. So it can cause deaths. So this is one of the most important things that complaints that MRI reports are not reaching. There's a possibility, but there are other certain deficiencies in the history form. That is, Kalutara sometimes it mixes up. Panadura also it mixes up. And THK, there are shortened forms use THK. It could be Candy, Kurunagal, Karapitian. So it's very important too. And of course, this outbreak, we have 162 reports idling there, because sometimes the name, everything is there, hospital is not there. Sometimes we thought of they might call. So 1.6 million has been used to test these 162. And but whatever the reason, mRNA is getting folded when the report is not reached. So little bit of vaccine, southern hemisphere vaccine is there, but it will expire in December. I was told that the stocks are not there. So the northern hemisphere vaccine usually, which covers November, January to April, is not registered yet. So in summary, seasonality exactly 90 minutes. Seasonality in Sri Lanka, we have a clear peak, November to February. It can be, of course, 1 month because it's not like a Christmas exactly on the same day. So it can come 1 month earlier or 1 month later. So influenza B can cause severe disease. We need all of your support to enhance our diagnostic services and to use the whatever available resources to maximum. And testing may on risk group, maybe in mid outbreak. It's not Sri Lanka adopting a special strategy. Even resource rich countries like USA in the even in the pandemic, they have adopted selecting and testing. So PCR is so expensive, but it's the main test. So we have to, and we may have to start treatment on suspicion or laboratory diagnosis. Thank you very much.
Thank you, sir. Our next speaker is Dr. Priyanka Jayawardena. He is a resident consultant physician at Visualiza Maternity Hospital. He is a member of National Dengue Guidelines Committee and National Influenza Control Committee. He will be speaking on physician's perspective. Over to you, sir.
Thank you very much for the kind introduction. My topic is influenza infection, clinician's perspective. The symptoms, it could vary from mild respiratory symptom to life-threatening pneumonia. This morning, one of my classmates came and met me. He told me, I have got a cough for last 3 days. What is this? Then I told, looks like influenza. And he didn't like it, obviously. So it could be very mild. And again, this morning, I was asked to see a patient who is in the ICU, admitted under cardiologist, and admitted with difficulty in breathing, with fever and normal CRP, and it looked like life-threatening pneumonia. So these symptoms in influenza could vary from very mild, just a simple cough, and up to this life-threatening pneumonia, which could be very dangerous. And most of the people, they come with high fever. We call it as flu. And the fever starts with chills, body aches, arthralgia, joint pain, and muscle pain. Plus, a cough, sore throat, nasal discharge, laryngitis, and cough and hemoptysis. So in this country, for the practical purpose, if somebody comes with fever, headache, joint pain, muscle pain, and loss of appetite, unless proven otherwise, it is dengue. If somebody comes with fever, headache, joint pain, muscle pain, loss of appetite, plus cough, sore throat, nasal discharge, and bit of wheezing, it's unless proven otherwise, it's influenza. So rarely, children can come with diarrhea and vomiting. And I told you the complication is the worst complication is the pneumonia. The incubation period is very slow, very short, maybe 1 to 4 days. The problem is low, it has low conversion. So it's important for a clinician because people come to us saying I had a fever and cough 1 month ago, still I have loss of appetite, body ache, still I am coughing. So most of the people, unless we give a steroid with the inhaler, they don't recover. So what happened? They go to a family physician, they start with one antibiotic, 5 days course of antibiotic, then another 5 days antibiotic, another 5 days antibiotic for this viral thing. And changing antibiotic to antibiotic for 1 month, then no improvement. So we have to give a steroid and we have to give an inhaler, meter dose inhalers to testing. Otherwise, they will be coughing for months. So I told you, if somebody comes with fever, headache, vomiting, headache, joint pain, and muscle pain, and cough and sore throat and nasal discharge, that is influenza. If somebody is coughing next to you, he's a candidate for influenza infection. But the practical purpose, that's a diagnosis, but we can't forget other differential diagnosis like there are other respiratory viral infections, which is not very common. Dengue is common. Leptospirosis, people could come with the lepto exposure, and again, there the platelet count is low, but there the white cell count is high, and the CRP is different to dengue and the influenza. So it could be either viral fever, it could be a bacterial infection, upper respiratory tract or lower respiratory tract. For the clinical purpose, we have identified high risk group: the children who are less than 2 years, and people more than 65 years old, and pregnant ladies, and adults who have other comorbid chronic medical conditions like COPD, heart diseases, chronic kidney disease, and uncontrolled diabetes, and people who are on immunosuppressants like steroids and diagnosed patients with HIV. So how this gets transmitted from one person to one person? So commonest thing is droplet infection. There's a person who is infected with the influenza and producing lots of secretion. If the person cough, these droplets can go and deposit in the next person's body, maybe the face. Second thing is direct contact. Somebody cough and produce those viral particles like phlegm, and second person will go and touch, and then he touch their face, nose, eyes, or mouth. Third thing is the via fomites. Fomites are other things, stuff that the ill person use those. It could be bed linen, it could be a nebulizer, it could be inhaler, and another person, maybe a healthcare worker, or maybe a family member, go and touch those things and get the virus. Then when he touches nose, eyes, or mouth, he gets the infection. So these droplets can only transmit only up to 1 meter. So if I have the influenza now, if I start coughing from this place, the girl who is in the front row won't get the infection. It is only 1 meter. So we don't have to worry about unnecessarily about this. It's only 1 meter distance transmission. Other thing, people can infect the others 1 day before they get their symptoms and up to 7 days. Or if we treat the patient with oseltamivir, and for 3 days, when the patient is fever-free more than 24 hours, the person is no more infected. Third thing is, if somebody gets fever and cough and so on today, after 7 days, usually they are not infective, but it is different in children. They will be infectious after a long time. So challenge the management for physician. The physician problems will be that that you can get a otherwise healthy person, young person, healthy person, who is sick with influenza, coming to a medical room. So he will spread to the infection to the other people, other patients in the ward. And the so-called high-risk patient, like COPD patient, CKD patient, maybe in the ward, otherwise normal, healthy person coming with influenza, he can transmit the disease to this high-risk group, then that patient will be at risk and maybe ended up with a problem, whereas the person who came with influenza going home without any problem. So in a busy medical ward, especially in the government sector, even in the private sector, there is not much of isolation facility. And in an epidemic, when we get lots of ill patients, then our ICU setup is very limited, and we have limited facilities. And again, in the government sector, we know that sometimes, especially in the epidemic, we have to struggle for medication. And especially when there's an epidemic, when you get lots of patients with influenza, we may get problems with influenza, and we may easy to educate the family and educate the patient. And when you get lots of patients and when they are ill, especially the whole family is affected with the illness. The worst scenario is if there's 1 or 2 deaths in the hospital, how to face the media. They are trying to create a story out of that, and we have to mediate that. Pregnancy is a high risk condition which is going to discuss separately. Treatment is it's basically simple and it's mainly symptomatic treatment. We advise the paracetamol to control the temperature and we don't recommend NSAIDs in influenza and dengue. I told you that the transmission is from droplet infection. That it means secretions. So we use medication to minimize the secretions produced by the patient. So chlorpheniramine is known as irritant commonly, and loratadine and nasal drops to minimize the secretions produced by the patient. That will help the patient symptomatically and that will minimize the spread to the other patient. Inhalers. Unless we start the inhalers from the beginning, the patient will be coughing for months and months. Nebulization, especially if the patient is having difficulty in breathing, we have to nebulize with bronchodilators like salbutamol, ipratropium, and if we can't give the steroids, especially in a person with diabetes and CKD, we have to use the steroid nebulizers like palmicol and oxygen when it is necessary. And ideally, it's good that if we can start the antiviral ocitalmab within 48 hours to get the maximum benefit. If the usual dose is 75 milligrams for 5 days, we don't know the value of higher doses and prolonged courses. It's a doubtful decision. But as Jude said, if you are clinically suspicious, we have to start the proper treatment without waiting for the investigation results. So, who are going to that? If it's an epidemic, you can't admit each and every patient to the hospital. So, then we have to think when somebody comes to the hospital, whether you have to think whether to admit or not. First thing, high risk patients. We mentioned that list. If the high risk patient comes with just a simple cough, like my friend who came this morning, you don't have to admit that patient. It's just ask them, you have to educate them. You belong to the bit of the high risk patient for influenza, but you have only come in 2 days' time, 48 hours. But if the person is having high fever and difficulty in breathing and progressive worsening symptoms, yes, we have to admit the patient and start hospital cover on admission. We don't have to, actually, honestly, we have to send these samples to the MRI just to get an idea about the prevalence, what kind of infection going on these days. It's useful for you to get the surveillance and reporting. But for the clinical point of view, it's not much of use. If you are doing it in the private sector, it's 5,000 rupees, nearly 5,000, it's lots of money. I don't think we should do that. So pregnant patient coming with influenza, then our national guideline says if you suspect dengue, if you suspect influenza, admit the patient. Yes, so we have to respect the guideline, but if the patient is just a mild cough like my friend, in the morning, you can ask the person to come tomorrow and day after tomorrow just to see what the situation. But if the pregnant woman is having high fever and progressive symptoms, then we have to admit the patient and you assess if you discharge the patient, you get them again in 2 days' time, assess the patient. But there are people, the low risk group. I can remember in 2013, you might agree with me, the highest amount of deaths due to influenza among the low risk group. That means the people who are having a low risk, they think, there's nothing much, they go to work and they do other jobs, and they came with viral pneumonia and died. So, though the patient belongs to the high risk group, still, if the patient is having progressive symptoms, especially difficulty in breathing, we have to admit the patient and start hospital work. Because we have to treat them, they also a category of vulnerable patients. So if the patient is not high risk group, maybe a schoolboy, girl, just a cough and cold, you don't have to admit, you just observe them as a outpatient. High risk group like pregnancy or heart disease patient coming with another influenza plus another problem. Heart pregnancy, they have asthmatics and heart disease. COPD patient has a CKD history and they are on steroids coming with influenza. Then you have to admit them and look for ICU and carefully manage them. And as I told, the regular dose is Stelmer, 75 BT for 5 days. We have to think about giving an IV antibiotic if you think there's a possibility of secondary bacterial infection. And it's important to give symptomatic treatment like nasal drops, chlorpheniramine, and loratadine likely to reduce the secretions. It will minimize the spread. Proper waste management is very important. When we ask them to, when they cough and sneeze, to cover the mouth with the tissue and how to discard it properly. Otherwise, the next person will touch and get the infection. And especially in the government hospital, if you are using a nebulizer, we have to provide a facial mask and tube to a connecting tube to the each and every patient. Otherwise, if you nebulize the influenza patient once and the next patient, if you're just asthmatic, can go to the infection to the next person. So we have to have a liberal stuff to give metered dose inhalers and spaces. And if the ward is crowded, it's better to discharge them little soon because otherwise we may not be able to pay the attention to the really sick people. But in an epidemic, if you are discharging the patient little early, it's a good practice to do a telephone call when they are at home just to see how they are, whether they are okay. So in a epidemic scenario, we have to have adequate supply of medication. So we have to discuss with the hospital authorities and the ministries to have adequate stock of antiviral, antibiotics. So those are the problems we face when we work in the hospital setup. An adequate amount of face masks, N95 masks, inhalers, nebulizers, oxygen, etc. And how do you prevent if somebody in an epidemic, and if you are getting patients to the medical ward, how are you going to prevent it? So we have to have adequate stock of disposable surgical face masks, and we have to educate the patient. If somebody comes to the hospital from the OPD, if you suspect the influenza, we have to provide the face mask. We have to identify. We have to send the patient the ward. Maybe if you on suspicion, we can start those tender from the OPD if the setup is organized, and we have to teach them good respiratory and hand hygiene. Whenever they cough and cold, they should close the mouth, nose with the tissue, maybe handkerchief, and then they should wash their hands. The people who attend to the patient, maybe the family, maybe the healthcare workers, also should wear the face mask, and they also should wash their hands whenever they attend to the patient. So we should, as a general idea, in epidemic, we should discourage them nose picking and touching the nose, eyes, and mouth, etc. And attending health care workers should wear the face mask, just a simple surgical face mask, not the N95. And in a ward, we should try to create a separate area for the suspicious patient. N95 mask is not essential. It's only for people who are doing special procedures, maybe the people, physiotherapists, or maybe the nurses who are sucking out the secretion in the intubated patient, not for the consultant, not for the SHO, not for the matron. If you are not handling those kind of not touching the secretion directly, is not necessary, and it's expensive and it's difficult to wear. And in epidemic, we have to educate the public to limit the hospitals and limit the public cases. So in an epidemic, it's very important to measure all the infection control measures because it's difficult to treat. Once they get the infection, the best thing is the prevention. So we have to educate the public regarding hand hygiene and personal protective equipment, that is basically face masks and the gloves. And the hospital staff should be trained for disinfection and sterilization procedures, because things like nebulizers, maybe catheters, suckers, we may have to use again and again. And cleaning and linen management, it's very important when the patient, when the linen and cleaning stuff are contaminated with viral particles. How are we going to sterilize those things? And waste management plays a big role. When they put their waste tissue papers and other contaminated stuff, who is going to do the waste management? And if the minor staff get disinfection, they will spread to the other parts of the hospital and other parts of the road. So it's really important to educate you. So if there's an epidemic, we have to educate the patients, educate the staff. That we have to conduct, maybe physician, maybe microbiologist, virologist should conduct the training programs to the staff, and we have to practically demonstrate how to do the disinfect, especially stuff like suckers and things, how to disinfect the things. Sometimes people used to just to clean with soap and water and use for the next person. So we have to educate those people how to do those things, and we have to educate the patient how to prevent the infection transmitting to other person. So training the ICU staff is very important. They know those things, but it's important. I think the microbiologists have a big role in their field for this purpose. And hand hygiene. And other thing, handling the panic staff. When you get hundreds and hundreds of patients in the hospital, people get panic. The minor staff and the nurses get panic. If I get the infection, I have a child at home. So we have to educate them. If you use the proper gloves and face mask, and if you wash your hands, you don't get this infection. And so we need to have special programs. Otherwise, they will simply may not come to the hospital to work. And you have to tell them no point going home, staying at home. If they go to the bank, there may be a person coughing at bank. If they go to the church, there may be another person coughing and sneezing at bank or church. So they can get the infection from those places. Also, no point avoiding the hospital. So when there's epidemic, it's in everywhere. So when somebody comes, it's very important to identify the complications. Usually in a bronchitis or pneumonia, you get lots of lung signs. When you put your stethoscope, you can listen to the bronchial taps. But in viral pneumonia, remember, the signs are minimum. So not much of taps, not much of bronchi. So the person might think, that the clinician might think, minimum lung size, nothing much. Viral pneumonia, not like bacterial, you don't get much bronchi, much cavitation. So sometimes the patient's oxygen saturation could drop without much minimal lung size. So we have to check the oxygen saturation. You may have to do the blood gas. And sometimes people get hypoxia, they get confused. I have personal experience. The person admitted with viral pneumonia, minimal lung size, and then hypoxic, which was not detected, and confused. And then the confusion was due to the hypoxia, and patient was referred to the psychiatrist, thinking that his patient was having a psychiatric problem, and proceeded with the hypoxia, lost the patient with viral pneumonia. So confusion and convulsion and those things are common. And we have, in an epidemic, though we have limited resources like ICU, then we have to create ICU-like places, like HTUs. So then we have to identify special places, maybe in a ward, maybe in a hospital, can be converted to a place like HTU. So we have to create a ward or hospital, a ward, part of the ward or separate ward, like a HTU setup. And then how are you going to find nurses with HTU training? So we can get some from ICU, we can train, do quick training, or other thing is the theater staff. We can cancel the routine theater list, routine list, and get those staff to the HTU and manage the patients, because that's the most important thing. And in an outbreak, a person like maybe a physician, maybe a director, hospital director, or virologist can't manage that kind of scenario. So you need the full team, to involve all these, to assess the situation and address the various aspects in an epidemic. And discharge, once the patient is clinically improved, we can discharge, but we have to tell them, when they go home, they have to complete the antiviral dose 5 days completely. Otherwise, they will develop resistance, and you have to educate the family regarding regarding the spread and the prevention. Notification is important because we need statistics about the patient, and in a high-risk patient, the higher level consultant opinion is better before discharging the patient with the follow-up plan. And we know the influenza vaccine is available now. It's a key vaccine, so we don't have to panic about it. It's safe vaccine, and it's given IM. Only issue is once you give it, it's valid, it's effective only for 1 year. So you have to next year you have to get it again, especially people who belongs to the high risk group. It's better to get yearly vaccine, and the cost is around 1,500 rupees negatively less than that in the private sector. There's not much of major side effects. And we recommend it for high-risk group patients and the healthcare workers. In pregnancy, the literature says you can give it in trimester. I think we better to avoid in the first trimester. Speaker will explain it to you. And usually, once you give the infection, it takes at least 2 weeks to develop the immunity. And current vaccine is safe, covers all the strains of the infection. Thank you very much.
Thank you, sir. Our next speaker is Dr. UDP Ratnasiri, a senior consultant obstetrician and gynecologist at Casa Street Hospital for Women. He is the president of Perinatal Society Sri Lanka. He is the secretary board of study of obstetrics and gynecology at PGIM, and he is the treasurer of SLCOG. He will be speaking on influenza in pregnancy. Over to you, sir.
Thank you very much for your kind introduction. So most of the management wise pregnancy and the adults are same, but I want to highlight the problems we see in pregnancy. Because we had few deaths over the last few years. Even now in this year, up to now 2018, another month to go, we had 8 maternal deaths contributing to influenza in pregnancy, and many more are admitted to ICUs and gone home with more morbidity. So, as Jude mentioned, that we don't send all the nasopharyngeal or whatever the swabs when we get influenza patients, influenza-like illness with respiratory illness with temperature, with cough and sore throat or cold. We treat them like influenza, so we call it influenza-like infection. But when we have the virology, we call it influenza. And when we have illness with X-ray findings or sometimes infiltrate, not to be felt in the aspiration of pneumonia, then we consider pneumonia. But as previous speaker mentioned, some of these lung signs may not be there with viral pneumonia. So we are a little vigilant when we get a mother with influenza, because when our household, so we listen to the lungs, we may not hear any lung signs. So the clinical features, fever and cough or sore throat, but it is not always typical with that. Sometimes there may not be fever. Sometimes other symptoms like chills, body aches, muscle pain, fatigue, headache, runny nose, and occasionally diarrhea and vomiting. So they also can be presented with the same illness. So these days, now our wards are filled with some of these fever patients. Some of them are dengue and also influenza. So we have to differentiate them between these two conditions for management, as Priyanka said. So there are some changes which occur during pregnancy, physiological as well as the immunological changes. You know, with the increase of the abdominal pregnant gravid uterus, it reduces the tidal volume and the lung capacity. And also in pregnancy, some physiological changes increases the cardiac output and as well as oxygen consumption. So it reduces some kind of suppression of T helper cell type 1 and cell-mediated immunity. So that impairs maternal response to infection. So with that, we place the pregnant mothers in a high risk group and complications are seen. So these are the complications: acute bronchitis, group otitis media. It's not only the lungs, but also viral pneumonia, secondary bacterial pneumonia, sometimes pericarditis, myocarditis, and encephalitis. So these are some of the other findings or the complications we can encounter in pregnant mothers. So the common one is the pneumonia with secondary bacteria. It's not only the mother. When it's a pregnant woman, we have to consider the baby. Now it has adverse outcomes with the fetal demise also. Maybe spontaneous miscarriages early in pregnancy, sometimes preterm birth. They go into labor and deliver prematurely. Intrauterine fetal hypoxia, may needing urgent delivery, sometimes emergency cesarean sections, and intrauterine death. Those are the worst ones in addition to the, so when the mother, pregnancy, you have high incidence of pregnancy induced hypertension, diabetes, some of them are anemic, rarely there may be heart disease or sometimes asthmatics, though they are also at higher risk than the normal pregnant mothers. So we have to consider them as a high risk group in addition to our normal pregnant mothers. So when you consider the care, so we have to consider them as a special group. When we consider the antenatal care for these mothers, especially in epidemic, we have to give them antenatal education about the disease conditions prevailing during this peak season. So dengue and influenza are the highlighted diseases, and we advise them to consult a physician immediately if they have flu-like symptoms. So now at the moment, the circular is issued when a mother has fever in pregnancy, one day to admit to the hospital. Because it's not only influenza, the other diseases like dengue is also needed to be excluded. But if it is now circular issued in the past, says start antivirals and all this, but now recently we change after our, I think, consultative meetings with the virologist and the other people. All these mothers need not be admitted to the hospital. If you suspect influenza with the primary clinical assessment, they can be given oseltamivir at the OPD level, provided they take it properly as Priyankar mentioned, and if the symptoms are worsening, to come back to the hospital and get admitted. So this is not happening at the OPD level with the OPD medical officers. It has to go through the obstetrician or the clinician in that hospital, this issuing of the drugs. So if they are complicated, like heart disease, asthma, or other diseases, even they are with the minor ailment, we admit them and observe. So when we discharge them, again, we advise them about the worsening of the symptoms and ask them to come back, because most of these maternal deaths, when we analyze the last few years, some of them have had initial treatment and gone home, come back secondarily with maybe bacterial infections or worsening of the other symptoms, and they die due to secondary causes, sometimes maybe the primary cause continuing. So adequate education, and even not only the patient, the caregivers like midwives, MOHs, the GP should make sure they come back to the hospital rather than, as Priyankar mentioned, continuing with the antibiotics for longer duration. So the American College of Obstetricians and Gynecologists, they have made this kind of a algorithm. When the patient is presented, assess the severity and treat them like low risk outpatient procedure, elevated risk inward, and when it is severe risk, admit to the ICU. So some of our mothers, when they come in with minor illnesses, most of them, they go home after admission or outpatient procedure. But when they come with bad illness or severe illnesses, some of them go to the ICU and get the ICU care. So this is the circulation. All pregnant mothers should be admitted to the hospital if they develop symptoms of signs of progressive disease or danger if they fail to improve within 48 hours of the onset of symptoms. Now, as Jude mentioned, we have to start this antiviral in the first 48 hours. If they are presented late, even then, better to start with the antivirals, because if the viral strain is highly virulent and if the immunity is poor, that virus can damage the lung very badly in the first 48 hours. That is the reason we have to start the treatment initially depending on the virus. So we don't get the viral strain, so we initiate. So MOH, that is the Medical Officer of Health, who are providing the care in the community. So they have to educate the mothers all about this illness, and PHM has the role of advising these mothers to come to the hospital in addition to their education and follow up once they go back home after the initial treatment. So it is a multidisciplinary, not only the doctors, everybody is involved in this care. Now, when we get the patient, it's not me, it's not the house officer and the team treating this patient, we get the physician involved as well as the anesthetist in case pregnancy is a different situation. Sometimes they go to preterm labor, sometimes they need ICU care, so we get the involved to the anesthetist. Sometimes beyond that, pulmonary physicians and the cardiac surgeons, if they happen to go to the ICU and go for further management like ECMO care. So it's a broader management to save the mothers when it's a severe disease. So we felt it is the vaccination, the primary prevention is the key, because most of our Western countries advise mothers to get the flu shot annually, but in our country we don't have it freely for mothers in the health department. So we advise if they can afford to get it as. So pregnancy, according to the Lancet 2009, it says 6 times more likely to get infected with the virus, and 4 times more likely to get hospitalized, and 6 times more likely to die than other adults. So death is pneumonia with subsequent respiratory distress required mechanical ventilation also very high. So I mentioned 8 confirmed maternal deaths out of 17 pneumonia cases in 2017. So 17 deaths for maternal mortality rates are big number, because we have only about 120 to 130 deaths. So out of that, 17 mothers die with respiratory disease, because our mortality with obstetric problems are coming down. The obstetric hemorrhage, hypertension, and the sepsis, these are overriding our maternal deaths with the other complications. So one year, that was about, I think, 2015 or 16, the top cause was the pneumonia, respiratory illnesses. So this year, I got this information from Family Health Bureau. Out of 11 maternal deaths of pneumonia, 8 were confirmed influenza. So we feel it's not only the mothers dying, but also the morbidity and the fetal demise, and the problems cannot be valued with the cost. So now recently we had a combined actually forum whether to get the vaccine for at least for the pregnant mothers, but the decision was it is not very effective, only 70% or 70% effective, and it's not very cost effective. But as obstetricians, our college feels you cannot value the life of a mother and a baby considering the morbidity and the mortality in our maternal statistics. So we screen for the symptoms at the beginning with the history. So we advise our nurses to check the respiratory rate and other problems as well as the oxygen saturation. If the oxygen saturation is less than 92, 94, they need more oxygen for the lungs, so we need to send them to the ICU for monitoring. And chest X-ray. Now we think chest X-ray is not ideal for pregnant mothers, but if the patient is not improving with the primary treatment, chest X-ray is important, because as Priyanka mentioned, there may not be many lung signs with the auscultation. But blood gas are needed for clinical indications cases. And we have to prepare for the other worse complications like preterm labor. Sometimes when they go into preterm labor with complicated pregnancy, they may need cesarean. We don't deliver them, at least, when it is the term patient, we wait for the symptoms and the signs to disappear and wait for spontaneous onset. But sometimes we see emergency situations like preterm labor needing cesarean section. So that is a worse situation, especially the anesthesia may be very harmful to the mother. So it is very important to consider these facts when you are managing. So as Jude said, now when we admit fewer mothers to the hospital. Our wards are overcrowded. So at least now we have the concession of sending them home with osteotomy for minor cases. And isolation may not be very possible in a crowded ward. So we need isolation facilities and the mask, hand hygiene and other primary care for the healthcare workers, and sending samples. Again, as Jude said, we are not sending during an epidemic. We treat them considering these are influenza treatment, but if they are not improving, worsening, then we send the virology. And we start oseltamivir without waiting for lab diagnosis, and we avoid NSIDs. And antiviral therapy has to be started as early as possible. I feel it's a safe drug for all 3 trimesters. We haven't had any problems. And severe cases, as Priyanka mentioned, we may consider giving double dosage for longer duration, more than for 5 days. And we don't advise chemoprophylaxis to get oseltamivir to prevent. This is the vaccination. And it should not be waited until the lab diagnosis comes. So we need to give adequate hydration, nutrition, like medication with the physician's involvement, antibiotics. Antibiotics we don't start initially unless it is indicated, antihistamines, bronchodilators, and rehydration of these mothers. So oxygen saturation, if it is dropping, she may need intensive care, but we also have limited facilities. So when we send all our influenza patients to the ICU, we don't have patients to be managed with the obstetric problems in the ICU. And we need to give sometimes corticosteroids for them for the lung maturation when they are coming with preterm labor with the influenza. So these are the indications we consider they need intensive care, and sometimes they may need further management with prolonged ventilation. If they need prolonged ventilation with ventilator support, they may need delivery of the baby prematurely sometimes to assist the ventilation. Otherwise, we don't deliver. So these are the questions we ask: whether they are in the elevated risk and needing intensive care from the patients, and delivery and postpartum care should be carried out in a separate area. Delivery, not in the common labor room, because when you admit them to the labor room, the other mothers also get. So routine antenatal care and the labor care, appropriate interventions, cesarean or whatever requiring for the obstetric complications, and they are at high risk of fetal distress because mother is not getting adequate oxygen sometimes, so fetus also may not be getting. So more cesareans. So we consider in all under the anesthetists during labor for the care in addition to the physician. So we try to keep them in the hospital minimal stay. Once they are recovering, we send them home with the education and advising them the deteriorating signs or the worsening signs and asking them to. So newborn, the baby should not be separated because they can breastfeed, and complications are avoided, and advising them to wear the face mask and hand hygiene, establish breastfeeding, and observe the neonates for the development of infection. Remember now, when you vaccinate the mother, the baby also protected for the first few months of the life. So it is a safety for the babies also coming from the mother during this antenatal intrapartum period if you vaccinate the babies. So these are criteria. We usually keep them 4 days and send them if they are recovered. So that has to be decided by a physician or the clinician, and they should be educated, and notification, as you mentioned, they have to be, those disease conditions should be notified to the MOH of the area about the illness. And so we advise, if possible, to get vaccinated. And the trivalent vaccine was available in the past. I don't know what's the vaccine available at the moment. And it reduces the influenza incidence of the mothers and the complications of the mothers and the babies. So now we read recently the reports that it increases the first trimester miscarriage, but that is not the vaccine of the present pregnancy. But if she has been vaccinated in the past and during this pregnancy, she has a little higher risk of miscarriage. And it's not only increases, it doesn't increase the fetal death, it use a protection for the baby. And I heard that it gives 70% protection with H1N1 strain when you are vaccinated. So if you can prevent at least 70%, I think that we have achieved something. So among pregnant women with confirmed influenza, the fetal death is doubled or more than that. So it protects not only the mother, it protects the baby during the vulnerable months of early life. So prevention of spread, I think you mentioned most of the things. I don't have to repeat them. So we advise them to stay at home, not to go to the public and spread the disease. And sometimes glucose. Now, mostly most mothers, they get this from the children. They go to the school or the primary or these daycare units and get them. So when you're handling these children, be careful wearing a mask and whatever the measures. So I think we have to be very vigilant on this epidemic now. As Jude mentioned, this is the time we have in my ward at in Kansas Street. At the moment, I have 3 patients. Some of them are with diabetes, some of them are with asthma. So we are keeping vigilant and we keep our staff informed. So thank you very much.
Thank you, sir. Our next speaker is Professor Vasanta Devasiri, a professor in pediatrics and presently the head of Department of Pediatrics, University of Pune. He is a consultant pediatrician teaching Hospital Karavidia and is a fellow of the Sri Lankan College of Pediatricians and presently the president-elect of the college. He will be speaking on influenza in children, a pediatrician's dilemma.
Thank you very much. And also thank you very much for inviting me for this presentation. My topic is the influenza infections in influenza in pediatrics, and sorry. Influenza in children, a pediatrician dilemma. Because I use this topic because it is a dilemma most of the time when they present. So what I would do is, first I will outline the outline of the presentation is, first I will do some salient features of influenza in children, and then the experiences in recent outbreak of severe respiratory illnesses in teaching hospital Karapedia, and then the difficulties of decision making in managing these patients, and then I would suggest a responsible approach towards management. I think the task it made easier for me because many of the things that I want to discuss have been discussed by the 3 previous speakers, so I can go through it fairly quickly about the features of influenza. Right, as mentioned earlier, it's a seasonal disease and spreads easily. That's the problem, and it could present in epidemic proportion. And the severity of the disease could vary from mild to severe. The problem is that when you have it in epidemic proportions, then there are many patients and many people will get complications as well. And other thing is, it's difficult to catch and control as there is an antigenic drift in the virus, so it keeps on changing. And that doesn't give a long-lasting immunity. And immunization is of variable success, and investigation and treatment could be expensive. So those are the problems we encounter in influenza in children. And then the other thing is that it commonly presents with the clinical features which I mentioned earlier: fever, runny nose, sore throat, sneezing, cough, headache, muscle pain, tiredness. I have this slide to show that how common these symptoms in children and how are we going to make a diagnosis of influenza when they present with these features. And only thing is that you will have to be more vigilant and be more careful during an epidemic of influenza when children present with these features. And then the diagnosis is usually there are two ways. One is the so-called rapid test, and there the sensitivity could vary because some of the negatives may actually have the disease, so that will be a problem. And the more reliable method is PCR, but the problem is the cost. And also the rapid test also, if it done in the private sector or in the hospital setup, it will cost a lot, about 2,000 to 3,000 per one test. And treatment is antiviral therapy with oseltamivir, and cost vary from 4,500 to 7,500 Sri Lankan rupees, depending on the age, because the dose vary with each children. And prevention is, I think Dr. Priyankara Jagan has explained it in very detail. Regular hand washing and the infection control procedures and face mask. And also the other thing is that yearly vaccination of high risk group is another approach you can have in prevention. The high risk groups in pediatric age identifies as basically infants or children and the children less than 2 years of age, and children who are having other chronic disorders or where that they have comorbidity. Because as they tend to get serious complication, they are identified as high risk group. But the problem is about 40% of children who develop serious complications are normal without any comorbidity. And comorbidity is a problem, but only about 40 to 50 to 60% of patients will have comorbidity who will develop serious problems. So there is a fair amount of normal children who might develop severe pneumonias and other complications with this. Right. So now, with this background in mind, I will move to some of the problems and some of the difficulties encountered in the epidemic in Teaching Hospital Karapetia in in March, April, and May, to show you this is not a straightforward thing as I have been describing so far, that we face a lot of problems and difficulties in making decisions, right? And anyway, this epidemic was detected, and there was as you look at this, you see that the number of admission to the pediatric ward has been increasing since March, but this was detected only in April. Right? So people were talking, probably that they realized that there are more children are getting admitted with respiratory illness, but the actions were taken only after April. So now we know, as Dr. Jurjama has mentioned, that when they are coming. So I think we will have to be more vigilant and detect the epidemic on time. And then the other thing is, one of the problems in this Karapet remember there were 21 deaths. And as you can see here, that the number of deaths compared to previous years increased in these 3 months, 13, 23, and 14. And these are the oldest in pediatric wards, and out of them, 21 of them due to respiratory illnesses. And the age distribution is, the majority of them are infants. And we were talking about comorbidity, but here also what you find is only half of them had comorbidity. When I say comorbidities, all of them, that half had serious illnesses like cerebral palsy, neurological disorders, and complicated congenital heart disease. But almost half of them did not have anything, and they were quite normal children when they infected, when they present with respiratory illness. And these are the complications that they had: convulsions, pneumothorax, pleural effusion, and pneumoperitoneum. And some other features in these children include: one of the most significant thing is there were no delay in seeking medical advice. What I am trying to say is that they were not admitted to hospital, but at least that they have gone to take treatment from wherever possible, from hospital or general practitioner or consultant, almost within first 24 to 48 hours. And out of the patients who died in Karapeti, 15 were transfers, and out of these 21 patients, 12 patients were admitted to hospital and was discharged within last 4 days. That was the second admission, right? They were discharged and were readmitted within 4 days after discharge. And most of these children who died had gradual deterioration after in the hospital after a few days, and they present the wheezing, fever, and wheezing is a fairly dominant presenting feature that they had. And their predominant blood gas abnormality was carbon dioxide retention and then hypoxia. Probably that there was some degree of respiratory or respiratory depression in them, right? And all received oseltamivir early after admission, right? And out of the 12 who had previous admission, 5 have received oseltamivir during the first admission. But others when they have oseltamivir first time could vary from 1 day to almost more than 2 weeks, right? The other interesting feature is the virology vary. I will show you. Right. I will show you. I'm sure that there must be some problem in changing it to this thing. But anyway, I will this virology that anyway I will explain it. What has happened in this PCR when you have done in this 21 patients, there were 15 patients as adenovirus positive, and 8 instances where the respiratory syncytial virus positive, and influenza positive in 5 episodes. There were mixed infections, right? There wasn't a single patient who had only influenza virus, right? But there were, if I can remember, 9 patients with adenovirus positive, alone positive, and about 11 patients and about 7 patients with respiratory syncytial virus positive, and influenza was, then there were 4 patients who had influenza as well. Sorry for the slide, I didn't check it when I came here. Probably there was some problem in the format. So again, what I want to highlight is what we found were other viruses were more common than the influenza virus. And even the children who had influenza virus, none of them had PO or only influenza virus. And then the bacterial cultures, most of them, about 20 during this patient, and these are the entire episodes. There were 27 positive episodes of nosocomial infections, secondary bacterial culture positive in these patients, right? And 6 of them had candida. About 3 of them died, but during this period in April and May, they have detected 6 patients who have candida. And there are only 2 episodes on pneumococcus. Probably that is community acquired, and even one of them died. So we don't know, as the most of the bacterial cultures which were positive were hospital acquired. And then use of antibiotics in these children who died, and all received broad spectrum antibiotics, right? And it ranged from 2 to 15 antibiotics. And that mean is about 8.5. So at least every child has received at least 8 antibiotics during this day or treatment. And again, the same problem is there. Anyway, it is all right, and I can remember this slide also. We have done ICT, yes, and we have done. Thanks. And we have done the rapid test in about more than 1,000 patients in the OPD, and there 16% were positive out of 1,160. Those are the patients who came to OPD in the morning, and some of them were treated, some of them were admitted, but the positivity rate is about 16%. That means 174 patients positive during those 2 months. I think we started in probably second week of April, and we went on until to end of May. And the viral etiology of PCR done in pediatric patients during that period, we have studied 316 patients, and that's why this okay, I'm glad. There were 62 adenoviruses only, and only 42 had influenza and respiratory syncytial virus in 74 patients, and negative in 28. The rest and this part is mixed in various combination between these 3 viruses. Anyway, the initial slide I got from the virologist had that, but I have removed it as it makes this slide too crowded then. So the dilemma is, with all these features, what are we going to do? And when to admit, how to diagnose? As I think that we know that it is a straightforward disease. We present with varying severity, with acute, with very with fever, and then with respiratory problems as well. But how to diagnose is a problem, right? And when to start, certainly is also a problem, and whether we have to wait for correct diagnosis, right? And then when to start other antiviral therapies, so fludarabine, because as you can say that many patients had respiratory syncytial virus, and there were many also with adenoviruses, right? And when to start antibiotics. And if you are starting antibiotic, what antibiotics, and how are you going to decide? And as I'm sure all of you are aware that it is being a common practice among doctors in the public sector and private sector as well to treat all respiratory episodes with antibiotic as well. And then the next section is, does vaccination help? Right? To answer this question, by looking at the actual figures we have got, it looks very difficult. And I think that for that we are in darkness, and that not much information we can get. But still, we will have to have some sort of approach. And sorry, and then, but still, with all this now, this is the dilemma, and probably that we don't know what is happening, and we don't know what we should do actually. But what I can suggest is a responsible approach to these patients as they keep on coming. When I say responsible, because I use this term responsible than rational approach, because I don't believe much on rational approach, and I think responsible will be better term because as doctors we have responsibility to the patients and to the country and with all the other things. So one of our responsibilities is to detect epidemics early. As we know that Dr. Jude Jama is already sending this influenza update, and then and we know that it will come in either November or December. So detect it early and to be ready. And when you are ready, one thing we can do is adhere to infection control policies. I think Dr. Priyanka Jayawardene has explained it in detail about infectious control, how to do it. Right? The next thing is maintain a high degree of clinical suspicion. The problem is that children with fever, myalgia, and upper respiratory system symptoms are quite common in pediatric practice. During a period non-epidemic, we do not regard them as serious. But in an epidemic, you will have to be vigilant and you are not supposed to miss them. Right? And again, if they are not very ill, they can still be sent home. There is no point of admitting all the children who are having these symptoms. But there must be a system that you can follow them up even if you send them home. The next thing is investigate adequately these children with influenza-like illness or respiratory infection for viral and bacterial etiology. Right? One way we can, I can, one way I can suggest is we can because one of our problems is that we are using antibiotics for respiratory infections, right? Maybe doing full blood counts and CRP and probably chest X-ray also, if will reduce the antibiotic usage, and also when to do antiviral therapy. Right? When I'm talking antiviral therapy, as everybody mentioned in the speech, that all patients will not need all patients will not need antiviral therapy, even if you make investigate and make a diagnosis. As I have told you, only diagnostic tool we have is um, the 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 indirect or the rapid test, which is also quite expensive. So anyway, if you do it, that doesn't mean that they should be treated and they should go home. They can go home if they are not ill and they can be followed up at home. And then we will have to have a responsible non-reactive. When I say that people react, get panic as there were a lot of talks going on about and in the media and everywhere, and not to react and to use antiviral and antibiotic therapy in a responsible way. And then adequate notification and report maintenance is essential. I appreciate Professor Jomadasena for some of the slides, and Dr. Nami Dantanarayan, the virologist, Dr. Bhagya Peach, the bacteriologist, and all the consultants and registrars of pediatric course in Karabiti and NSU, PSU, and ETC. Thank you very much.
Thank you, sir. Now it's time for the discussion, and I would like to invite all four speakers and Dr. Bhushan Jayasuriya, the chairperson for the evening, to the head table. Over to you, sir.
Good afternoon, ladies and gentlemen. I think we are a little late today, but we have had 4 great presentations. And first of all, on behalf of the Expert Committee on Communicable Diseases, I thank Dr. Jude Jama for organizing this, for sponsoring this sort of thing. He was the one who wanted the seminar organized early before the epidemic that could come. So he was the real motivated behind this meeting today. So, and we have had four great presentations. Before I make my comments on influenza, which I always have very strong views on it. I would like you to give your comments and questions. There are some questions from the webinar which we can, when we get it, we'll discuss them.
Thank you very much for the expert committee and everyone here giving a very good overview on influenza. There are a couple of things that I want to ask about. One thing, with whose opinion the vaccination was not approved, according to Dr. Ratnasiri. I mean, who is the one who decides the national vaccine recommendation? Or I don't know that part. That I need to ask that question. And also, second thing is overuse of being a microbiologist, I am very critical over using antibiotic, and even these cases, lots of cases, antibiotic could have been started from the primary care physicians like GPs itself, because our parents' education is not adequate regarding antibiotic. They also pressurize on prescription of antibiotic even to the children. In Dr. Devasiri's cases, antibiotics being used 16 antibiotics for those children, if I remember right. So that is, I mean, deadly. If any one of us have been using 1 or 2 cefuroxime or amoxicillin, we know how much it is hard for us. And it shows in those cases isolation of candida shows the antibiotic pressure. I mean, in children, microbiome, microbes in our body is very important. So killing them also helpful to reduce the immunity and clear even these viruses when they have the primary infection. So there are lots of things to learn as clinicians and lots of precautions to take as clinicians. And they are minor things actually, rather than going for antibiotic. The major thing I want to stress is antibiotic not to be used, and very vigilant where to use. Thank you for all the speakers.
Jude, would you like to answer the first question? I am aware of what has happened.
It's a lot complicated. Well, to be honest, like we had a subcommittee, like the Deputy General, because from the Karapitia, even the trade unions and a lot of people were actually making allegations against the Minister of Health, or whoever responsible person is not giving a right decision on. But of course, there was a subcommittee where after 4 meetings, they review whatever the scientific evidence based. There's no particular person or an institution taking the decision. It's a majority decision based upon certain discussions. I would say heated discussions actually.
Actually, we didn't have local available data. So we had mostly the mortality and the morbidity data, but not the virology data. As well as we didn't have the so that was one problem, and also the cost. That was the other, I think mostly the cost was the another cost effectiveness. Now it said not 100% effective, only the range 40 to 70%. So if you are vaccinating all pregnant mothers, we have about 335,000 pregnant mothers a year. So it will be very costly, and we are reducing only 40 to 70%. But as a college of obstetricians and gynecologists, we thought that is a very good protection. With the secondary measures, we can reduce primary measures, secondary measures. But majority is only a minority representing the obstetricians, but majority thought it would be better not to introduce. So that is the reason that it was not introduced this time. I think we need more epidemiological data, not the deaths. I think the epidemiological data now, if we can have a continuing study of admissions and show them these deaths, pneumonia deaths are due to the virus itself. You can't say because virus may be the initiation, but secondary bacterial infections, comorbidity all contribute for the deaths. And we find very expensive methods of treatment when they go to the ICU. That cost is not calculated on top of the vaccination cost. So that is the difficulty there. So we still feel it is cost effective. That is the reason most of these developed countries spend. But the ways that the government spend money for other reasons, I feel it is more cost effective. Thank you.
I need to my comment. I know there was a committee appointed by DG, and unfortunately, this committee has given a report which I think is wrong, basically wrong, because 8 mothers have died this year. 8 mothers have died last year. Total number of mothers dying in this country was 100. About 10% of mothers have died in this country because of influenza. That is good enough evidence to give influenza vaccine to our pregnant mothers. What is the cost? 1,500 rupees. At least, what is 1,500 to 350,000 in this country? When you can billions of rupees on jeeps and this and that, it's nothing. It is for us to, the medical profession, to advocate and fight for us. The committee, unfortunately, has not given a proper ruling. We have to fight. And I request the College of Obstetricians to give a statement saying that you recommend that every mother be given the influenza vaccine. Surely, 1,500 rupees, even a laborer can afford 1,500 rupees, the government can't give. The second thing which I openly elected the ministry is not, it does not openly tell that a vaccine is available. Why can't if the ministry can't afford the vaccine, why can't the ministry say there is a vaccine available to people? They don't tell. They say wash your hand, this and that and story, and put posters on that. But they don't say vaccine is available if you want to buy 1,500 rupees. That is not proper education. So those two things we must do. And therefore, I don't think we should do advocacy for this. We have to advocate. I don't know about the studies regarding the children. There's a problem there, it looks. But then, if all countries in the world, basically developed countries, are giving influenza vaccine to children, why are we waiting for studies? Did we wait for studies when we hepatitis B vaccine in this country? No. Just because somebody offered, we took it. So these stories are all nonsense. Lack of money is absolute nonsense. Thank you.
Thank you, sir. Absolutely. That is something that I want to stress as well. Regarding the costs, actually, oseltamivir cost is higher. I mean, it was obvious now, 1,005 vaccine and 7,500 or more oseltamivir over 12,000. That's again another thing. And also, any people will like to buy it on their own if the vaccine is available. I mean, if the government is scared to spend on that, any person will buy. Now, a lot of people come and ask where to buy, and so many people call even to us. So why is it bad? I mean, as somebody mentioned, are we waiting more deaths? So it is very pathetic in that context also. Yeah, then now this time I read an email sent from the flu alert by Dr. Jude. This time the prevalence strains he has identified. Now it is ready. So the prescription is northern virus. Is it right, Jude? Yeah. So then why don't we buy it in time? Now after virus is here, when we buy the vaccine, there may be even other complications also associated. So there are enough lessons to learn from developed countries where there are seasonalities and there are enough data. So why are we waiting anymore?
Anyway, the one of the it is available, and anyway people can buy it, but the committee decided this not to make it available as a national policy. That means one factor is cost, and also there's a problem in even storage will be a problem, because there's a vaccine that you will have to get down and use it, and the half-life is only about 1 year. And all these factors are considered, and also the efficacy of the vaccine is also that there were doubts, and depending on that they decided that it is not enough to apply it as the national policy.
Thanks, sir. Actually, as of now, 56 participants have joined the online webinar. However, there is only one question from Dr. Ilakshika Ranasinghe. What's the mode of transportation if it's a dry soap? What's the mode of transportation if it's a dry soap?
Dry soap.
Dry soap.
Dry soap. Yeah, thank you very much for the question. We have the viral transport. Usually, a dry soap we do not accept it if it is come with a dry soap, right? But if there's a dry soap of course and the viral transport medium is not there, this happens because viral transport medium sometimes we issue 5 or 10, and by an outbreak it dries in the sense it goes very quickly. So if you have a dry soap, of course, one thing of course we don't encourage cotton soap. Cotton soap will inhibit the PCR. So there will be popular soap. Sometimes you can purchase from a pharmacy. So dry soap you can put it into normal saline. Normal saline means preserve that. Right? We use the viral transport to enhance it and preserve it. So in an outbreak situation or this encounter, sometimes we do get call from Kabuttegama and other things.
Sorry, I want to break your discussion. There is a request from we are blocking some ambassador's car apparently. 1303 is blocking that car. Our car from here 1303.
It's all right. So just to sum up, if you have the dry soap, please immediately put it into normal saline. Sterile normal saline would be good, but if it comes to as a dry soap, of course, unfortunately, we are not in a position to accept it. And of course, just to add, formalin also, it's not a good medium. Formalin for PCR, and even in alcohol will inhibit. So putting into alcohol also, especially lung samples, we do not encourage. So normal saline, lung tissue samples should be transported in normal saline or viral transport medium small samples. Thank you, sir.
Yes, and about your comment about antibiotics, I totally agree. Because the problem probably was that it was a situation that people get panicked and they started reactive. And when they are not responding 1 day, 2 days, that people try to keep changing antibiotics. And that is why it came talked about because of switching. And remember, what I have discussed is only the patient who had died. And as you can see that about more than half of them were transfers from base hospitals and the district hospitals, and about 12 of them that was second admission as well.
There's one more question.
Yes.
Yeah. There's one more question from Dr. Mahesh Komuge. Can we buy also from the pharmacy? Can a GP prescribe them?
That's a good question. Unfortunately, asaltamivir is only prescribable according to our guidelines by a qualified physician. General practitioners, of course, they might prescribe, but you cannot buy it over-the-counter drug by showing the prescription. But as of May 18th, National Medical Regulatory Council took a bold decision with along some representative from the colleges also, where pharmacists, especially Osusala can dispense drug to a registered medical practitioner. It should be actually a consultant, and they have a drug like tramadol. They have a register where they can check it. So they took. I was informed. I was in the committee. So Osusala, they are available to a consultant's prescription as a kind of a countable drug. That the special register is there. It's available in Osusala.
It's due to influenza. I think it's very underestimated. We see lots of elderly people who are living otherwise healthy. When they get influenza, initially the usual scenario, they go to a doctor close by. One thing he doesn't think it's influenza. He doesn't have ability facility to prescribe the antiviral. So he gives some amoxicillin or something like that. And then the second round start and he gives another set of antibiotics. So they come to the hospital with kind of very poorly stage, and then other comorbidities start. Maybe diabetes getting blood sugar goes under control, not under control. Then the heart disease pop up, and the other metabolic things like renal failure start, and the sodium goes down or up, and those things come, and they die with some other thing, maybe MI, maybe a stroke or infection with the secondary bacterial infection. So the death certificate goes as MI, ischemic heart disease, stroke, septicemia, acute chronic renal failure, something like that. But the initial root cause was influenza. I think we have lots of personal experience similar to that. Lots of elderly people, otherwise were okay, having a good life, were victim of this illness. So though if the government can't afford giving a vaccine, I think it's high time we have to educate the public, saying that it's available. In that case, what the government could do, they could buy the vaccine from the company and give a subsidy price, and then make it freely available to the community. So it's, I think, as medical professionals, our duty to educate them regarding the flu vaccine, like in other countries, to go to their GP and get it done maybe as outpatient, as a routine every year.
If you chair, with your permission, I would like to add two important things. Now, our general practitioner, now of course, I think Vaccine Forum and Dr. Prasanta Sirivardhana, they are actually making some effort to make a study of influenza-like illness to get some etiology from the first contact. So that's a very good initiative next year. That at least take some 2-3 centers in Colombo and take general practitioners, because they're the first contact. So I think Sanath Hettige was in the same group. They're very initial. And of course, just to make DMH and Council Street as centers for a period of 12 months to follow up a very basic, because the thing is they need solid evidence. That's the thing. So they are coming back to square one after discussions. So those are my concerns, but 10,500 rupee PCR is maybe, if you plan it, at least 2 centers. Because the thing is, once we will start, denominators were not there. I mean, of course, medicine, sometimes we need to discuss, but no, denominators were not there. Like, we have 8 deaths, then of course, the public health people were asking, so we couldn't answer, what is the denominator? So I don't know, but sometimes, because I think the policies has to be taken on perhaps solid data was the argument by most of the things. So this again, those two considerations are really important, because we can actually initiate perhaps next year.
Can I make just a comment now regarding the vaccine? Now actually, now this influenza vaccine, there were 2 manufacturers who applied for registration maybe more than 10 years ago, right? But that time also the same problem cropped up, right? Because they said we don't know what the strains are, and so then there was a problem. So as a result, that time actually, that was the time that at MRI this influenza center was established, and fortunately for Dr. Geetani Wickramasinghe, who trained Jude, she was responsible and she did a surveillance with the help of the WHO. So we were able to identify the strains. Then only these vaccines were in the pipeline maybe for about 5 years. I think, sir, you will know, because earlier when you were you were the medical director at GSK. So it was a big problem, right? I had to use lot of force at these meetings to say that we need the influenza vaccine, not as a national policy. Yes, true, okay, but at least to make it available for the people, so that at least the high-risk people, I think any pregnant person, actually it is not even 1,500. Even in the private sector, it is less. It's one of the cheapest vaccines. But 1,002, 1,080, and actually with the hospital also will charge in the private sector. It is about, I think about not 1,200, right? Maximum will be 1,200, which anybody can afford.
Now, when they buy in bulk,
It will be even cheaper. If you have a tender or like that, we know, because I was in all the technical committees, tender, when it's a large bulk, even it will be less. If they want, they can get the multi-dose vial even. They want to make the cost even less. So now they are saying that, okay, what is the evidence? So there is no other way out. If you want to introduce, at least for the pregnant mothers, you have to do a study and show the policymakers, okay, these are the things, so that at least for the high risk patients. And now the other problem is now the Southern Hemisphere vaccine. Now at the moment there is no vaccine at all for the last 2 months. Now we are going to have the outbreak. Now you will see. And now the other problem is the Northern Hemisphere vaccine, which is usually available during this time, is not registered. Because they were saying, like, if you have the Northern Hemisphere, our strains are Southern Hemisphere, then they will mix up, but still there is cross protection. That is well known. And some years, it is the same strain. Sometimes there is a slight difference. Not all the strains. If I am wrong, just correct me. Sometimes one strain, there may be a slight difference, but it has been shown in influenza that there is whether Southern or Northern. Now, when the Southern Hemisphere vaccine was, when it was available, people going to US and UK, they took that, though it is the Northern Hemisphere. But they came back and said, doctor, we never got the flu. That has protected us. But now there is no vaccine, so I think we have to say that at least the Northern Hemisphere, so that during the time when the Southern Hemisphere is in the manufacturing process, now the agents are saying it will be available on the end of April, which means, our first epidemic is. So you have to expect, and you will need a lot of oseltamivir. So I don't know.
Thank you. I think we have had a good discussion. We have failed miserably, the medical profession in this country, to protect our people. My simple question is, if my wife is pregnant, am I going to give the influenza vaccine? Yes. If that is the case, why can't you allow? I can't advocate for the rest of women in this country. That is a simple question. Forget about all this evidence. Evidence is enough for us to give my wife vaccine, then give it to the others. That's a very simple thing. We have failed. I think we should not give up. We should continue fighting. Thank you very much. And now we have to give this certificates to the speakers. Just one more.
Thank you, sir. I would like to invite Dr. Bhushan Jayasuriya, the past president of TSLMA, to distribute the tokens of appreciations to the speakers. Dr. Jude Jayamaha. Dr. Priyankara Jayawardena. Dr. UDP Ratnasiri. And Professor Basanta Devasiri. Thank you, everyone.
Thank you very much.